Uh, as Dr. Lasser has already described the staging of lung cancer with starting from very limited stage to limited stage SCLC and then extensive stage SCLC. So I'll be talking mainly about limited stage small cell lung cancer and role of radiotherapy in the same. So any distribution of disease which can be covered in a tolerable radiation portal is termed as limited stage small cell lung cancer. The need, what is the evidence for adding thoracic radiotherapy to chemotherapy was given by meta-analysis by Pignon and Wade et al. It was a meta-analysis comprising of a large number of patients showing an absolute survival benefit of about 5% at 2 and 3 years. And so the intrathoracic tumor control rate was improved by about 25% with thoracic radiation therapy. The next issue was about sequencing of thoracic RT and chemotherapy because small cell lung cancer is largely considered as a systemic disease. So we are tempted to complete systemic therapy first and then start the local therapy. However, there were some advantages and disadvantages of both the approaches, and eventually it was seen that concurrent thoracic radiation which is started along with chemotherapy, maybe in the second or third cycle of chemo, gives a better median survival and 5-year survival rate compared to when it is given at the end of chemotherapy. Of course, some acute toxicity such as hematological toxicity and esophagitis are more when we give the two concurrently. And was seen that in a meta-analysis that each week of extension beyond that of the study arm resulted in an overall absolute decrease in 5-year survival of about 2%. So earlier, shorter and more intense thoracic radiotherapy programs improved the survival rates. So at our institute, we try to initiate thoracic radiotherapy along with second or third cycle of chemotherapy. Now, management of, this is just a summary showing you that the management of limited stage small cell lung cancer depends on the loco-regional extent as well as the performance status of the patient. In very early stage or very limited SCLCs, surgery is also an option, of course, after proper pathological mediastinal staging. And after surgery, the patient can be taken up for systemic therapy. Systemic therapy is for observation in small cell lung cancer, irrespective of the margin status or nodal status. Systemic therapy is always indicated. Mediastinal radiation has to be added if it is N1 disease onwards. Again, this is one stage where stereotactic SBRT can be considered in medically inoperable patients. If nodes are positive, then irrespective of the tumor size, we approach as per the systemic concurrent chemo RT approach. Then there is no role for surgery or SBRT. In patients who have a poor performance status, that is 3 to 4 PS, which is not due to small cell lung cancer, then the patient is usually referred for best supportive care. So what are the various fractionation schedules that we have for small cell lung cancer? The most common one that is used, actually not commonly used, but the established schedule is 45 grays in 30 fractions, 1.5 gray delivered twice a day over a period of about 3 weeks. Another approach is concomitant boost, where a dose of 61.2 grays is given in 34 fractions in 5 weeks, and twice daily radiation is given during the final 9 treatment days. And then there is a standard conventional fractionation of 70 gray in 35 fractions. There are some ongoing studies like the Convert trial and the CalGB trial, which are comparing the standard BID approach to once daily approach with a dose of 66 grays, and again the BID approach with a dose of 70 grays given once daily. So these are some of the fractionation schedules that are used. The one that we use at our institute is 66 gray in 33 fractions over 6.5 weeks. So do we give, what are the volumes we treat? One of the primary things to be remembered is that we treat only the tumor and involved lymphatics. We do not give elective nodal irradiation in small cell lung cancer, because the micrometastasis in unenlarged lymph nodes is thought to be eliminated effectively with chemotherapy. And in order to safely deliver the required curative doses, it is better to keep the target volume as much restricted to the involved field only. After initial chemotherapy, that is 1 or 2 cycles have been given, for tumor delineation, we use post-chemotherapy residual volume as the GTV. If possible, we try to include the pre-chemo volume in CTV, but if that is uh, causing violation in the V20 constraint of the lung, then we restrict ourselves to the post-chemotherapy volume. For the nodes, we take the pre-chemotherapy involved stations. So tumor, post-chemotherapy residual volume, and for nodes, it is the pre-chemo involved stations. And the same thing is highlighted in NCCN. When thoracic RT has to be given in adjuvant setting, that is very small subset of patients who may undergo surgery in small cell lung cancer. In that case, radiotherapy is indicated if mediastinal lymph nodes turn out to be positive. Extensive stage SCLC is mainly managed by the medical oncologists. And here, role of thoracic radiation is again debatable, because there was a kind of practice-changing study published by Slotman and his group, who showed that addition of thoracic RT to a dose of 30 gray in 10 fractions to residual disease in extensive stage small cell lung cancer who have responded to chemotherapy can gives progression-free survival benefit, but there was not much benefit in OS at 1 year. However, the overall survival at 2 years was found to be better in the radiotherapy arm. So can we have a curative intent in extensive stage SCLC? Again, there are further studies being done on this. One is the CREST trial, another one is RTOG 0937, in which after completing chemotherapy, if the patient has complete response or partial response, they are being randomized to no thoracic RT versus RT to the thorax as well as to metastatic sites. The primary endpoint is overall survival, so let's see what comes out of it. Next is prophylactic cranial irradiation. The concept behind this is that there is a good number of, there's a significant proportion of patients who develop brain metastasis in small cell lung cancer, and blood-brain barrier prevents the penetration of most chemotherapeutic agents, leaving the brain as a sanctuary site for relapse. So there are meta-analyses which have shown that in limited stage patients, those patients who show a CR or a partial response or stable disease after completion of their locoregional treatment do benefit from prophylactic cranial irradiation. However, so the protocol that we follow at our institute is that once the patient has completed all the cycles of chemo and locoregional radiation to the thorax. A re-evaluation is done with PET-CT and MRI of the brain. If the primary site shows complete response or partial response, and there is no evidence of obvious brain metastasis, the patient is taken up for prophylactic cranial irradiation. We treat it with slanting field technique, and the dose recommendation is 25 gray in 10 fraction, that is 2.5 gray per fraction. The expected side effects are as seen in whole brain radiotherapy, though they may not be as bad because the dose is less, the dose per fraction is lesser. Patient can experience some fatigue, alopecia, nausea, and headache. And some patients can have somnolence. And can we have hippocampal sparing in prophylactic cranial irradiation? Well, this is not the standard of care. Hippocampal avoidance is not being practiced as a standard of care right now, but there are some studies which are investigating the same. Because here we have to be careful about intracranial relapse more rather than avoiding the hippocampus. Other areas of role of radiation in SCLC is in the form of palliation, that is when the patient comes with frank brain metastasis, the dose is 30 gray in 10 fractions. In case of bone metastasis, again 13, 10 to 25 or 8 gray single fraction, or in patients who present with superior vena cava obstruction. Of course, in SVCO, again, radiotherapy is not the first line of treatment. Usually the treatment starts with chemotherapy. If the patient does not respond immediately to the same, only then we consider the patient for radiation. Then spinal cord compression or for relief of hemopsis. So this is a table giving you a summary of some paradigm shifts in management of small cell lung cancer. And this is a small section on the role of post-op radiotherapy, which I could not cover yesterday. And as I said, I'll be covering it today. There are just 2 or 3 slides. This is for non-small cell lung cancer. Post-op radiation in non-small cell lung cancer lost favor because of the large fields of radiation that we used to use 2D conventional planning causing a lot of morbidity, and actually we ended up with lesser survival in patients who received POT due to cardiac morbidity. But what we have to see is that now the techniques have changed and the radiation color wash doesn't look like this. This is evidence which showed some 5-year survival benefit for patients with N2 disease. Stage 1B through stage 3, this was a part of a trial which was mainly concerned with chemotherapy, but as a subset analysis, what was concluded was that in patients with incomplete resection or positive N2 disease, there is a role of post-operative radiotherapy. So the radiation portals have become more conformal, where we are including only the bronchial stump, the resected involved mediastinal lymph nodes, and ipsilateral hilar nodal regions and stations. We are following the guidelines from lung art contouring protocol. The PTVs depend upon the institutional practice, the method of immobilization, and after assessment of tumor motion. Dose that is being given in R2 resection is as high as a definite dose. For R1 resection or extracapsular spread of disease, 54 to 60 gray, and for R0 resection is 50 to 54 gray. So this is how the color wash looks like. Thank you.